This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending here, and I'm joined today by our research fellow.
And I'm Dr. Alara. Today we're looking at a fascinating new study from the journal Neurologia medico-chirurgica, published in 2026. The paper is titled Association between Early Diagnosis, Surgery, and Prognosis in Patients with High-Grade Glioma, Retrospective Analysis of a Real-World Healthcare Claims Database in Japan.
This is a crucial topic, Ilara. We know that high-grade gliomas, especially glioblastoma, are associated with a notoriously poor prognosis. But this study looks at a variable we don't always quantify in the literature, the patient's first point of contact in the healthcare system, and how that impacts the timeline to surgery.
Exactly. The researchers utilized the Japan Medical Data Center Claims Database, which provides a massive look at real-world clinical practice. They identified 540 patients who fit the profile for high-grade glioma, specifically those with a diagnosis code of C71, which is a malignant neoplasm of the brain, who had also undergone surgery, radiotherapy, and received temozolomide.
So these are patients receiving the standard of care STUP protocol or similar aggressive management. What did the demographics look like?
The median age was actually quite young at 54 years. In fact, 70.9% of the patients were under the age of 60, and about 63% were male. What's really interesting is that they focused on 375 evaluable patients who first visited a hospital different from the one where their surgery was ultimately performed.
That's a common scenario. Most patients present to primary care or a local clinic first with nonspecific symptoms like headaches or cognitive changes. Did the data reflect that?
Very much so. The most common department visited first was general internal medicine, accounting for 43% of cases. Only 13% of patients went straight to a neurosurgical department as their first point of contact.
And that's where the delay begins. Let's talk about the initial visit to surgery interval. This is where the paper gets quite specific about the time lost.
It's a significant gap. For patients who first visited a neurosurgery department, the median interval to surgery was 19 days. However, for those who started in a general internal medicine department, that interval stretched to 35 days.
That's nearly a 2-week difference for a rapidly progressing tumor. Did they look at a specific cutoff for what they considered a timely surgery?
Yes, they looked at the proportion of patients who underwent surgery within 21 days of their initial visit. For those starting in neurosurgery, 62.2% met that 21-day window. But for the internal medicine group, only 37.5% made it to the OR within that time frame.
It really highlights a systemic bottleneck. If the patient doesn't land on a neurosurgeon's doorstep immediately, the diagnostic workup and referral process significantly eat into that critical preoperative window. But the million-dollar question for our residents and colleagues listening is, does this delay actually change survival?
The results suggest a strong trend. The researchers looked at the 3-year overall survival rates. For patients who first visited a neurosurgery department, the survival rate was 72.7%. For those who first visited other departments, it was 57.7%.
That's a numerical difference of 15%. That's clinically massive, even if the p-value tells a slightly more nuanced story.
Right. The log-rank p-value was 0.39, so it didn't reach statistical significance in this specific cohort. However, the authors state that the results suggest the treatment of high-grade gliomas was delayed if patients first visited non-neurosurgery departments, leading to these numerically poorer outcomes.
It's a classic real-world data challenge. While the statistics didn't hit the magic 0.05 threshold, the trend is clear. Early neurosurgery consultation and surgery may improve the outcomes of patients with high-grade gliomas.
It really emphasizes that for medical students and residents on internal medicine rotations, a high index of suspicion and an early referral to neurosurgery is vital. The paper concludes that these delays in non-specialized departments directly correlate with that extended interval to the operating room.
Time is brain isn't just for strokes, it's for oncology too. If we can shave off those 16 extra days by streamlining the referral pathway from internal medicine to neurosurgery, we might be looking at a real impact on long-term survival.
Absolutely. It's a call for better integration between general practice and specialized neurosurgical care.
Well, that's a great summary of this Japanese claims database study. It's a sobering reminder that our surgical success starts with the referral timing. Thank you, Dr. Alara.
Thank you, Dr. Alara.
And thank you all for listening to the Neurosurgery Hub podcast. We'll see you in the next episode.